Let me introduce Dr. Albert Park, who is the Chief of Pediatric Otolaryngology at the University of Utah. Dr. Park has an extensive experience in cytomegalovirus, has led an multi-institutional trial with the NIH, and has had quite a bit of research in CMV over the years, and I would consider him the foremost authority in CMV and hearing loss. And we're actually very excited to have him come and talk with us today about CMV. So thank you very much, Dr. Park.
Great. Well, thanks so much, Dr. Slattery, and thanks again for asking me to present to this great group. It really is quite an honor. And certainly, if you have questions during this presentation, don't hesitate to ask. And I'm hoping this will be a great dialogue. So I'll go ahead and get started. So I was asked to talk a little bit about this condition, which has really been really dear to my heart for a number of reasons, which I'll explain a little bit in a moment. Wasn't sure if this was a CMV, not CMV, but CME presentation. So I did have a non-disclosure here, and I do have some NIH funding, and I'm a consultant for a number of different companies and also involved in some industry-supported studies. I guess of relevance is I will be talking about this antiviral called valganciclovir, which is not FDA approved for congenital CMV infections, but I hope to share with you some of the data and why I think it definitely has a role in treatment. So part of the reason that I also wanted to present this information to you is that we did do an online survey to both neurotologists as well as pediatric otolaryngologists, and this has been published in the Oto Open Access Journal. And we had 70 respondents. Average age was 48 years with a male to female, about a 2-to-1 predominance. And these are sort of the take-home messages. We found that, unfortunately, many did not know about the incidence of this condition or disease progression, especially with related to hearing loss. That was very little knowledge about the time sensitivity diagnosis, nor the role of dry blood spot. There was very little in terms of those using any sort of CMV testing in their own practice. And many did not even know if their own institution actually performed screening of any type. And most did not know about the role of antiviral therapy. And so that's what my hope is for this presentation, is to give you a little bit of some information regarding these very important facets. And I think as otolaryngologists, neurotologists, that we definitely have a role in this condition and that we really need to be more in the forefront. So my objectives of this presentation is to convince you that I believe this is very, very much an important topic. And I want to relate that in terms of the story of DD, which I'll present to you shortly. Maybe provide some answers to some of the main points of the survey that I think many of the respondents had less than optimal knowledge about. And then also maybe provide some practice recommendations for your practice. So I'd like to start with a story, and this is actually Caitlin Hill's family, and they were very kind enough to share their story about Caitlin, and so I'll go ahead and just play this tape for a moment.
My first pregnancy was so easy. A couple of ultrasounds before Caitlin was born, there were things happening medically, with ultrasounds that made us nervous. And I just assumed when they said, well, we've got this problem, but this one cleared up, that it really wasn't that big of a deal. I always felt a little bit left down in that way, that we didn't have a whole lot of information. Nobody said, hey, this is actually a big deal. Your baby could be in danger. I don't know if they wanted to protect our feelings or what, but it seems like it was underplayed a little bit. She was quiet when she was first born. They did a C-section and they had her, and we kept waiting for that cry. And we did hear it, but it was a little. She was 4 pounds 10 ounces, so she was very small. She had all these health issues. It's really common. It's the most common congenital virus.
So let's talk a little bit about CMV. CMV is a herpes virus. It's in the same family as HPV and also chickenpox. It is species specific, so it only affects humans, and it's the most common cause of non-hereditary sensorineural hearing loss. And so understandably and justifiably so, there's a lot of discussion and emphasis on the genetic components of sensorineural hearing loss. But I think CMV has been somewhat of an orphan condition in terms of not really getting the due recognition that it deserves, because it can account for up to 20% of all pediatric hearing loss. And the cost of congenital CMV is in the billions of dollars, which is on par with much better understood and or better known conditions such as otitis media, actually. And so transmission is typically from the mother to the fetus, and there's two common routes. There's a primary infection, which is in a mother who was never exposed to the virus until the pregnancy, and then unfortunately passes it on to the fetus during that time, or the seropositive mother. So this is the mother who actually has already been exposed to the infection, but then either through reactivation or through a secondary or other strain passes it on to the fetus. And actually in the developing world, the secondary infection actually is a more predominant route of transmission. In terms of the presentation to the infant, there's sort of a spectrum where it goes from the asymptomatic, where really there's no signs or symptoms of infection, to the symptomatic. So the symptomatic occurs in about 10% of all cases. In these children, they unfortunately can present with prematurity and a whole host of organ involvement. This shows you in this picture a child with disseminated petechiae throughout the face. This is an axial CT scan that shows some evidence of calcifications that's very characteristic of this condition. And in about half of these children, they have evidence of sensorineural hearing loss. Asymptomatic makes up about 80% of these children where they show no signs or symptoms of infection. And then you have this cohort of about 10% of these children who have just isolated hearing loss. And this hearing loss can present at birth or later in life, which can be a challenge for diagnostic purposes. In terms of diagnosis, there've been a few large studies comparing saliva to urine. The virus does have a tendency to be trophic to the salivary glands and also to the urinary tract. Saliva is obviously pretty easy to obtain and thus in many cases is favored over urine. However, in these two studies, they cited a 26 to 41% false positive rate. And we think that that's because in many of these cases, what's happening is that the mother through breastfeeding is essentially exposing the child to virus in that fashion. And so these are postnatal acquisition of virus in these children, which is not associated with hearing loss. And so this causes sort of a false positive result. And so I often favor in my clinical practice, if possible, getting urine. And if I do have a child with a positive saliva result, I will want to obtain a confirmatory urine before that sort of 3-week window. The 3-week window is sort of key. It's sort of our standard in terms of distinguishing between congenital versus postnatal infection. That's been sort of our approach in general. Now, what about dry blood spot? So dry blood spot, it can be and was at one point thought to be a potential way that we could do mass screening for all infants in the US, because every child in the US gets a metabolic heel stick, and then that's placed on a Guthrie or DBS card. And so this was a major study by Suresh Bapama that was published in JAMA in 2010. And they looked at using 7 institutions, predominantly from the East Coast, looked at dry blood spot samples and compared that to saliva cultures. And relatively large study of over 20,000 infants. And unfortunately, they found that their sensitivity of dry blood spot was quite low. Even using a double primer with, at that time, state-of-the-art DNA extraction techniques, they only had about a 34% sensitivity. Now, Mark Slice at University of Minnesota and Sheila Dollard at CDC are in the middle of a pretty large joint study reevaluating this using now much more modern techniques. And the most recent data suggests sensitivity is as high as 70 to 80%. So certainly a marked improvement over Suresh's data, but still indicates that it's not the sort of 90 to 99% sensitivity that we would hope to achieve, especially if we're looking at universal or mass screening. So I'm going to relate a little bit about sort of how I got into this field and how my interest really got piqued with this. It started back around 2006 or so when I was asked to be a chapter champion for an EDDI conference in Washington, DC. And while I was there kind of hanging out, I bumped into Amy Donahue, who at that time was the deputy director of the NIDCD. And she lamented the fact that there was really very little being done on the basic science aspect, even on the practical aspect of congenital CMV infections. And so that sort of piqued my interest, because at that time I was certainly seeing a large number of kids with pediatric hearing loss, but really identified very few with congenital CMV infections. And part of it was because we didn't really have the diagnostic tests and didn't know really what to look for. And so we developed some collaborations. One is with Jim Bale, who was at University of Iowa and now was in Utah, who really had pioneered a lot of the early surveillance testing of this condition. He's a pediatric neurologist. And then David Hilliard, who's the medical director in the ARUP, which is a national reference laboratory. And he's currently very busy now with COVID screening. But at that time, we had talked about trying to develop some sort of testing algorithms and assays for CMV. And in this picture here showing a child slaughtering, we developed an assay that's CLIA validated for saliva. And then we also developed the first CLIA validated dry blood spot testing using PCR technology. And around this time, I met Dee Dee, and this is about the fall of 2012. She at that time was 18 to 19 months of age. Unfortunately, was developing progressively worsening hearing. She actually failed her newborn hearing screening, and this sort of very limited auditory brainstem testing at 3 weeks showed the following: a 30 decibel response in the right and 25 on the left. And unfortunately, audiology just recommended follow-up in 9 months. They didn't pick up on the fact that she had an intrauterine ultrasound that showed some cystic changes in the brain, and this was confirmed on a subsequent ultrasound. And by the time she presented to me, she had a normal otologic examination, but this sort of mild hearing loss had progressed to a right profound and left moderate, and actually within the sort of month period where we were working her up. So I got a saliva CMV PCR just because we had now this new validated test. This came back as positive. This doesn't confer a definitive diagnosis, so that's why we obtained the dry blood spot, which was positive. This confirmed a definitive diagnosis, and during that time, her hearing started worsening, and we started her on some antiviral therapy, but unfortunately, she ended up with bilateral profound loss, required bilateral cochlear implantation, and actually a revision procedure 2 years later. And this graphic just shows you sort of the progression that occurred from 5 weeks of age all the way through 20 months of age. And so Daisy Dutray actually is DD. This is a picture of her, and this is her mother, Sarah Dutray. And I vividly remember my conversation with them on the day they presented to me that day back in 2012. And Mom is very much involved in child and healthcare issues, and felt herself to be very educated, but never had heard of congenital CMV infection. And she had mentioned that her mother is Representative Menlove, who is at that time a House member of the House of Representatives in Utah, and very active also in maternal and childhood health issues. I didn't think too much of it because I have many conversations with families who've never heard of this condition, and certainly agree that there needs to be greater awareness, but really didn't think too much of it until about 2 weeks later when I was summoned to the Department of Health with Sarah and Representative Menlove and a number of investigators on CMV research who I could never get into a room. And so we started to brainstorm, and we talked about congenital CMV infections. We talked about sort of our workup. To the left shows you the workup that I often will have to do in terms of trying to define or determine a diagnosis for CMV, and it just illustrates some of the complexity because of the time-sensitive nature and that many of these children present later in life. And we talked about newborn hearing screening because, as you know, it's universal and it's very successful. 99% or so of all infants get universal screening by 1 month of age or so. And we thought, well, since CMV is a common sort of cause of hearing loss, why don't we sort of piggyback onto an existing successful universal hearing screening program and see if maybe we can identify children in that fashion. And so this is sort of the algorithm showing you the relative simplicity of this approach. We also talked about awareness. And so this is a national survey showing that in over 4,000 participants, that very few men and very, very few women have even heard of CMV. And this is compared to rubella, toxo, and other conditions where the awareness is much higher. And so through these legislative efforts, Carl White, who is the former president of NCHAM, Jim Bale, who I presented his story to you before. We were successful in getting legislation passed almost unanimously through the Senate and House. This is the signing ceremony at the University of Utah, where we have Daisy, Sarah, Representative Menlob, and then Governor Herbert. And this is a signing ceremony with me prominently displayed in this signing ceremony. So this is the sort of outcome of this legislation. It charges that the Department of Health provide a education program to inform caregivers about CMV, also to educate providers and other organizations offering childhood services about this disease process, and then the screening component in which medical practitioners test infants who are less than 3 weeks of age who fail 2 newborn hearing screening, 1 in the birth hospital, 1 in the first ambulatory visit, to also undergo CMV testing, and then to inform parents of the ramifications of a positive result. And so this was implemented back in July of 2013. One of our studies that we looked at in terms of determining the outcomes or ramifications of the screening program is shown here. This is a publication that we have in Pediatrics from about 3 years ago. And what we wanted to look at was the sort of outcomes or effects of this screening process on timely diagnostic hearing evaluation. As many of you know, we have the sort of 136 guidelines in terms of in trying to identify as well as treat children with hearing loss, because we know that earlier identification of these children has a positive impact on speech and language. And we found that if you, in the periods before early CMV screening, we had about a 56% rate of those who actually got timely diagnostic hearing evaluation, which is 3 months. And then after the law, we found that that number increased to 77%. In fact, in the children who underwent CMV screening once the legislation was passed, and this is again the first two years when we're developing familiarity, and I can definitely say we didn't have a refined program, but even despite those limitations, almost 90% of those children who underwent CMV screening got their diagnostic hearing evaluation by 3 months, versus 61% or so who got it when they were not screened. And so I think the major take-home message that we found from the early CMV screening is that it not only benefits the children who are found to be CMV infected, but actually benefits all children who fail their newborn hearing screening. And so that's a much larger group of children who benefit from this program. And this is just an important paper that was published back in Pediatrics in the 1990s by Christy Yoshinaga, showing that if you identify and treat children early, meaning 6 months of age or younger, that regardless of the type of hearing loss, regardless of whether it's profound, severe, moderate, mild, that their language quotient scores are better. And that's highlighted in the dark bars, versus those children who were identified and treated later in life where their speech and language scores were not nearly as good. And so this is sort of the motivation of early newborn universal hearing screening. This also shows in this study, this is a survey of EDI programs throughout the country, and it shows that unfortunately, despite our success in over 99% of children getting hearing screening, that only about half of these children get timely diagnostic hearing evaluation by that 3-month period. And thus, again, early CMV screening has a positive impact on aspects of the universal newborn hearing screening program that's lacking. So in July of 2013, Utah became the first state in the country to implement an early CMV screening approach. And this is kind of what I see in my backyard with the flowers, the Indian paintbrush, and the mountains in the back and such. The sort of national landscape, this is a little bit dated, this is January 2020, but it just illustrates to you that there's been a huge change in terms of what's happening nationally, where a number of states have looked or passed legislation incorporating early CMV screening, or at least awareness programs. And California has actually been somewhat involved in this process too, and I think they got relatively close to enacting some sort of legislation, but I think that's still very much pending, and we'll have to see over time whether that will come to pass. So what about treatment? And I wanted to present this case to illustrate both how early CMV screening can be efficacious in terms of providing an etiology for a child's hearing loss, as well as how it may also in the future provide diagnostic treatment. So this is a 2-month-old child who failed her newborn hearing screening. And so this law again had been passed for a few years, and so immediately triggered CMV testing. We did a saliva CMV PCR, which was positive. And then because we know that this can result in CNS abnormalities or other sequelae, we got a head ultrasound, which showed bilateral periventricular leukomalacia. And this child was started on an antiviral therapy for 6 weeks. I've now followed her for maybe about 6 years, and her hearing testing has been stable. We know that through natural history studies of congenital CMV infections in children with hearing loss, that the child who is identified with hearing loss with congenital CMV has a greater than 50% chance of progressive loss by this time. And so this would seem to indicate that an antiviral administered early may forestall or ameliorate the effects of congenital CMV on hearing. And her speech and language also has been progressing normally. Now, there have been some studies. There's a study that's looked at the symptomatic children in terms of the use of antivirals. And this is a slide I showed you earlier with the child with petechiae. And again, there's a host of organ involvement that can occur. And there is a general consensus that children who are symptomatic or severe infection would benefit with antiviral therapy. The antiviral therapy typically used is valganciclovir, which is a prodrug of ganciclovir. It's believed to work through blockage of viral replication. The nice thing about valganciclovir is that it can be administered orally and is rapidly then converted to the ganciclovir. It is FDA approved for treatment of CMV disease in children who are receiving transplants. It is not FDA approved for treatment for congenital CMV. Though I know David Kimberlin and the Roche group, which manufactures this medication, have been looking into obtaining FDA approval. What they have found in this cohort, in these children with severe infection, is that if you do a randomized clinical trial, which is what they did, comparing longer treatment, which is 6 months, versus the shorter treatment of 6 weeks, that you have a large proportion of children with normal or a maintenance of normal hearing or improvement of hearing, as shown in the blue portion of this pie, 77% versus 64%, which was statistically significantly different. If you also look at neurocognitive outcomes, they found that language and receptive communication scores in children who are treated with a longer duration of antiviral therapy do better than the children who are treated with a shorter or 6-week therapy. The controversy these days is, what about the more prevalent and the children who have less severe disease? So this is a quote from Joseph Bocchini, who's an infectious disease doc down at LSU and considered a leader in the field. And he states, and I think this is the general consensus when I've talked to physicians throughout the country, that antiviral therapy is not the standard of care of children with congenital CMV infection with isolated hearing loss, since there's insufficient data to support the safety or efficacy of treating these infants. Now, we've done some work in our lab looking at our mouse model for CMV, and we have found that in those mice that administration of ganciclovir does provide otoprotection or prevents progressive loss. This is published, I think, in one of our, I think it's maybe in Laryngoscope. And so certainly from a proof of concept from the basic sciences, this also makes sense. We've also been able to confirm that it does reduce viral titers with administration. But in terms of the clinical arena, that's not been addressed or been answered. And so that's been the motivation for our NIH-funded clinical trial that's ongoing. This is to look at the outcomes on hearing as well as speech and language in this group of children through a double-blinded randomized clinical study. We also want to look at safety of valganciclovir because it's been shown to cause neutropenia. There's been some concerns about the effects for fertility and even carcinogenesis in animal models. And then we also want to look at the pharmacokinetics, because really I think the future of the field is also looking at sort of a personalized drug concentration approach that can potentially enhance efficacy as well as reduce adverse effects from this medication. And this is sort of a study design graphic just showing you how this study's been set up, where again, we're including children who are CMV positive, but only have isolated hearing loss. They don't have any other manifestations of the disease. They're then randomized and then either go into the arm that undergo valganciclovir therapy or those who are placebo. And then we follow them for a period of about 8 months after randomization, up to 20 months after, and then obtain hearing outcomes. We look at safety, and then also look at pharmacokinetic information. And so we have now about 30 sites that are involved in this trial, 3 of them in California. And it's actually going to be international because we're now also going to engage the Ontario group. So that's University of Toronto, as well as McMaster and Ottawa's Children's Hospitals groups will also be joining us in this trial. Well, we've talked a lot about sort of hearing targeted approaches for this, but there are limitations for this screening. Now, one of the reasons we started with this is we felt that it's better to walk than to sprint or run, because this is a long haul sort of issue. And there's also challenges in implementing something of this scale. But there have been discussions about universal CMV screening, and this is actually a position paper that was published in Lancet. Dr. Rawlinson is a infectious disease doctor and basic scientist in Australia, and he had a number of sort of leaders in the field involved in this, and they actually came up with a recommendation that universal neonatal CMV screening should be considered. There are some work that's being done throughout the country as well as in Canada. Ontario actually has implemented a sort of pseudo-universal using dry blood spot. The reason I say it's pseudo is because they're using dry blood spot versus a urine or saliva, and dry blood spot, as we talked about earlier, has at best maybe a 70% sensitivity, and so you would be missing children even through this sort of universal approach. There is no state or there's no large network that has implemented universal CMV screening in the United States. And I think one of the reasons is because of the cost and logistics for doing this, as well as about 80% or so of these children would be expected to not have any sequelae from congenital CMV. And so you would be identifying quote unquote normal children. And so those children can be difficult in terms of counseling. You know, how do you address this issue? As well as many of these children, unfortunately, often are lost to follow-up, understandably so. Now, this is a paper from Karen Fowler, who looked into a comparison of the different approaches, hearing targeted versus universal screening. And sort of the take-home message that she found from her study, and this is part of the CHIME study, looking at those 7 or so institutions around the country, is that 43% of CMV infants would not be identified through hearing-targeted early CMV screening approaches. And she was able to ascertain this by comparing a group that underwent universal screening. Now, there are some limitations in this study in that they didn't really provide any methodology for how the newborn hearing screening was done, nor any clear methodology in their diagnostic ABR testing, which I think could have some effects on this outcome of 43%. And they also did the ABR testing in the first few months. And really, you need to validate that with additional ABR and or behavioral testing, because as many of us know, the early results don't always are consistent with later results. In terms of cost, that's a big issue when you're looking at universal versus targeted screening. This is a paper by Soren Gant, at University of Vancouver. And I just wanted to point to you the cost to identify one child with CMV-related hearing loss, assuming it's a $50 cost per test, would be about $90,000 if you do universal, versus about $3,000 or $4,000 if you do a hearing target. So hearing target is certainly a much less expensive endeavor. Now, how do you compare that to universal hearing screening? This is a somewhat dated paper, but I think it's by Dr. Karen in Pediatrics in 2002, where they show that universal newborn hearing screening to identify one child with hearing loss is about $21,000. So a little bit in between the cost of universal and hearing targeted. Certainly hearing targeted is less expensive. So if you were to screen all children in California, you'd be looking at essentially testing about 500,000 children versus about 5,000 if you were to do hearing targeted. And certainly there would be significant logistical challenges, personnel costs, transport, laboratory infrastructure, insurance coverage, and then also the education and counseling of the approximately 80 to 85% of children who are expected not to show any sequelae or signs from this infection. One of the sort of gratifying things that I've had as being involved in the Valdair NIH trial is actually working with a number of sites throughout the country in implementing hearing targeted. So to be a participant in this site, you have to have some sort of early CMV screening program to be able to enroll potential candidates. And in UC San Diego is involved, Stanford, as well as UCSF. All those programs within the last 3 or 4 years started from scratch and started developing hearing targeted CMV screening approaches. And it's been very gratifying to see the success that I've been seeing both in California as well as nationally. But we don't. The only constant in life is change, and in Utah we've continued to look at other approaches to see how we can improve our identification. And one of the things that we've now looked at is what's called expanded targeted screening. And so, as I showed you, a lot of the data was related to failed hearing screening. But we also wanted to look at, what would happen if we started testing moms who there was a suspicion or even documentation of maternal CMV infection? Or what about small gestational age or intracranial findings on an ultrasound or thrombocytopenia? And so we started to look at this issue. And this has really been generated by the neonatologists and pediatric infectious disease and pediatric neurologists coming to us and wanting to really see if we can identify more of these children. And this is a paper that was published, or actually it's been accepted at the Journal of Pediatric Infectious Disease. We looked at about 700 children out of about 85,000 that were born during this period of about, I think it was about 2.5 years or so. And we identified 21 children with congenital CMV through this sort of expanded target screening approach. That comes out to about 14 cases of severe CMV per 100,000. And part of the reason we wanted to also identify these children is that there's data already out there that shows that identification of these children and treatment with the antiviral drug valganciclovir can really benefit these children in terms of hearing outcomes. And so these are sort of the low-lying fruit in terms of who we can make an impact in identifying. Now, there's a study that's from University of Vancouver looking at if you don't have a screening program, what is the sort of case identification of CMV, and it's about 4.2 cases. So we found that we were able to significantly increase our numbers through this expanded screening program. We would expect if you were to implement universal, though, you would get about 26. So we certainly are not identifying all the children with symptomatic CMV infections, but we are, I think, making a difference. And so I think that's been something that has been very gratifying. So as I mentioned to you earlier, before I sort of joined or was involved in this endeavor, I would maybe see 1 child a year with congenital CMV. Now I see 2 to 3 a week with congenital CMV infection. So it's really, I think, made an impact in Utah in terms of the families that we are able to identify. I want to go back to Caitlin just to give a little bit of a follow-up on what her condition was and what the family's sort of perspective is on this, because I think that's very important. So let me go ahead and replay this tape.
I didn't think that, 7 years down the road, we would still be in speech therapy and going to doctor's appointments and dealing with effects of this one virus that caused so much damage.
I was going to be really sick. And then somehow I was getting better. So when I was at least 4, I got my hearing aid.
So now she is 7 and she is completely deaf in her right ear. She's got a moderate loss in her left ear. And so she uses a cochlear implant on the right side and the hearing aid on the left side.
I'm pretty happy that Jesus made me up with my arm because I don't get trouble a lot.
She doesn't see those kind of dividing lines that we see. Everybody's her friend. Doesn't matter who they are, how they look, how old they are. They're all her friend. And she's so open and she's so happy and she'll give anybody a hug. And when she grows up, she wants to make cookies and give them to people. And that's just Caitlin. She just is loving.
Nobody knew what it was, but I wish we'd been given a little bit more information.
It's not hard. It does take a little bit of a shift and some intentional behavior, but you do that all the time when you're pregnant anyways. You're accustomed to that. You understand the importance. I think that moms are willing to do anything to protect their kids as long as they know about it.
So in conclusion, I hope I was able to share and convince you that this is an important issue, that it should be incorporated in any child who has idiopathic sensory hearing loss, and it can be done. I've identified children as old as 5 or 6. So when I started doing dry blood spot testing in Utah, they would only keep the dry blood spots for 3 months. But I think part of the success of this program and a great collaboration with the Department of Health helped in them keeping these now for several years. And so I think that's been great. So I'll have kindergartners who unfortunately are identified with hearing loss at that stage, where we're able to determine the etiology. In California, you guys keep your dry blood spots, I believe, indefinitely. And so you could potentially really identify a large number of children who present to you with idiopathic hearing loss. I certainly feel that some sort of form of early CMV screening should be implemented nationally, because I think it makes a lot of sense. Insurance companies will pay if you have a child who fails your newborn screening and undergoes CMV testing. And it makes a lot of sense because it's part of the diagnostic workup, as well as dry blood spot testing in a child who's older. Targeted screening is something that we should be doing anyway, at least expanded screening. Like if you have a child who's microcephalic, it's not Zika. This is most likely congenital CMV infection. And these are sort of approaches that really can be pretty easily incorporated into your practice. It doesn't take a rocket scientist to do these sort of things, and yet this could really make a huge impact for the families who you see. I want to acknowledge the Valier team, and so we had a conference when we were trying to get everybody set up to be activated, and this is June back in about 2 years ago, and these are research coordinators, site PIs, infectious disease, audiologists from throughout the country who came to this conference. And then I also want to acknowledge my research team. So I have a number of medical students, undergraduates, residents, and fellows who've really been keeping me going. They ask the right questions and been wonderful to work with, as well as our clinical team here. Marissa Diener, Angela Shoup, John Carey, David Hilliard, Joe Crow and Pofo. It's just been a great group to work with.